again, I always joke with my non-GI oncology colleagues that we do have exciting trials. So we do, and we do have groundbreaking, practice-changing trials. A challenge that many of us talk about is we come to ASCO, we get this exciting data, we're really excited to implement it, and then we go back on Monday or Tuesday morning to clinic and we can't actually implement it for a variety of reasons, insurance approvals or patients not understanding these newer agents or hospital challenges. I'm curious how you all manage that. I mean, it's a big question. We could probably talk about that for an hour, but when you get excited about things at ASCO, how do you then implement those in your practice when you go back?
So I think it's always starts with educating our staff, telling them this is the new drug and why it is important and why it has been approved, and staff includes our nurses, our APPs, our pharmacists. So that's the first step. Secondly, we take it to the patients and discuss those data. I often actually tell them to look at the paper, and I share the paper with them. I think that is good, so that an educated patient has a better prognosis, in my opinion. There's no randomized study to support that, but it's our duty to educate our patients. And then, when there is a solid data, I think most of the time, insurance approval go through. It might take, some talking, some, writing a letter and stuff like that. But even I was able to use some of the drugs off-label, even before FDA approval. As for example, immunotherapy in the neoadjuvant setting in localized MSI-high GI cancer patients. So that's kind of the step-by-step we go about it.
Anything else to add on that?
It's a challenge. I mean, it's insurance that really runs our worlds in a lot of ways, but I agree, be willing to put in the time. Sometimes it is doing a peer-to-peer, sending these appeal letters. It takes a lot of time and effort, but I often have success in doing these processes. So I think it's upon us to take that time. If you really think that this treatment is the best for your patient, you have to invest that time.
By the way, ChatGPT can write the letter for you.
They can.
And I use that.
Right. I do too. I have done it numerous times, and I've been effective many times.
Yeah, absolutely. Yep.
We should have had this meeting several weeks ago. Oh, my goodness. Yeah.
So as we get nearer the end of our time, I want to discuss for a few minutes emerging things that are happening in GI oncology and colorectal cancer. What are you all excited about? What is something that you're waiting to hear? We've talked a little bit about some of the studies that are coming out, but if you had to pick one or two things that you think in the next 1 to 5 years are going to be transformative in the colorectal cancer space, what do you think those are going to be? I'm going to start with you.
I think today's discussion was largely focused on the metastatic settings. I want to pivot and talk about the kind of early stage setting. We're moving towards kind of a non-surgical approach, be in rectal cancer with TNT, MSI high patients with immunotherapy. So that's something that I'm really excited about. And I think that'll be really exciting to play out. And then the role of ctDNA and MRD, I think, will mature and we'll have data that will shape how we write our guidelines, how we take care of patients. So excited about that.
For me, I think it's immunotherapy, and I'm a little surprised that I'm even saying that. I've been kind of a naysayer about immunotherapy in GI cancer. It's not been to this point largely that effective, but the BOT/BAL regimen, has kind of shown some light that maybe we can make progress, and MSS-CRC, and I'm hearing about other immune checkpoints that are being developed that are in fact specific to GI tumors, and so I have a lot of hope actually now that we may find that kind of PD-1 checkpoint that might be there in CRC and in GI tumors.
So I'm very passionate about using immunotherapy in neoadjuvant setting for localized GI cancer patients who are MSI high. I have actually launched a national database. It's called Dream GI, where I'm collecting data on these patients who are being treated outside of a clinical trial because they cannot get surgery because of their health condition or they're older, for those reasons. So my point is, when I pull this data on a few hundred patients, and if I can show it can effectively induce complete remission without any surgery, without chemotherapy, without radiation, and they stay in complete remission for a long period of time. I have published quite a bit of data. I have a poster coming up in ESMO GI as well to highlight that you can actually keep these patients in complete remission 2 years or even beyond. And I think Since we know the immunotherapy activity is, it persists in the body, it's durable. I think these people are probably long-term survivor, but we will know. So that's one area, I work very actively, talk to various sponsors about supporting the studies and, get immunotherapy for these patients, for which sometimes you have to do letter and peer review and all that. But I have been successful to get immunotherapy for all these patients, and I'm putting them in my database, so that I can show that surgery is not the only option for these patients. So that's my area of interest at this time.
I will tell you the two things that I'm very excited about. I agree with all of you. Immunotherapy, I think, again, just like Suneel said, I never in my life thought I would be saying that I'm excited about immunotherapy advances in the GI cancer space. So I think that is fantastic, and I'm really hopeful that we'll continue to see more data. And the second thing I'm really excited about is the ctDNA data that's coming out, because I think it can have a direct impact on the quality of life of patients. The Europeans always joke that we over chemo our patients. And so I think that if we can use ctDNA to potentially decrease the amount of chemo we're giving patients, or utilize it to better guide our therapy as to who needs more adjuvant, who needs less adjuvant, I think that will be transformative, especially as we're seeing younger and younger patients diagnosed.